Next presenter is Dr. Mahmood Hasan Khan. His presentation is regarding as an under-detected tsunami, Jeopardized cardiologist. Dr. Mahmood Hasan Khan, please.
Assalamu alaikum and very good morning to all. Assalamu alaikum, respected chairpersons, learned panelists, and dear audience. I am Dr. Mahmood Hasan Khan, serving as Associate Consultant, Evercare Hospital, presenting my case. It's an under-detected tsunami, jeopardized cardiologist. I have nothing to disclose. As we all require a calmness in the environment and in everywhere we go, because calmness matters. Nobody would like to have a tsunami. So our case, Miss A, 25 years old, normotensive, non-diabetic, having exertional shortness of breath with recurrent loss of consciousness for the last 4 years. On examination, JVP was not traced, bilateral pedal edema, left parasternal heave, palpable P2, no thrill, first heart sound is normal, and second pulmonary component of second heart sound was loud. A soft systolic murmur in left, second and third intercostal space with grade of 2 to 6. Best heard in breath hold in inspiration without radiation. Vitals, pulse was 88 per minute regular, blood pressure was 100/70 millimeter of mercury, and respiratory rates were 24 breaths per minute. Her ECG showed right atrial enlargement and right ventricular hypertrophy with signs of overload. Chest X-ray showed bulge pulmonary bay, cardiomegaly with RV type of apex, and straightening of right heart border. Transthoracic echo showed dilated main pulmonary artery with its branches with dilated RV. Dilated RA and RV with mild RV dysfunction with TAPSI 15 millimeter. Paradoxical septal motion, otherwise no regional wall motion abnormality with fair LV systolic function, having LV ejection fraction of 55%. Apical four-chamber view showed moderate to severe tear and severe pulmonary hypertension with PSP 96 millimeter of mercury and dilated IVC. Dilated and prominent hepatic veins were also noted. Mild 10 to 15 millimeter circumferential pericardial effusion without any signs of tamponade were also noted. Transesophageal echo showed this. So in short, our two echo findings were right-sided pressure overload with severe pulmonary hypertension and right ventricular systolic dysfunction. 24-hour Holter showed normal study. So we were confused. What is the cause of it? High-resolution CT chest and CT pulmonary angiogram showed dilated main pulmonary artery with its branches and incidental findings of a MAPCA. So, in short, CT pulmonary angiography showed dilated pulmonary arteries, no shunt anomaly detected, no evidence of thromboembolism with MAPCA. Cardiac catheterization showed this. Cardiac catheterization with oximetry showed no significant oxygen step-up seen at atrial, ventricular, and arterial level. Shunt anomaly was excluded. Cardiac catheterization pressure studies also done, and it showed these findings with cardiac output 2.1 liter per minute and peripheral vascular resistance was 23.8 U/min. So our final diagnosis was idiopathic pulmonary arterial hypertension, having mean pulmonary arterial pressure of 64 millimeter of mercury, mean capillary wedge pressure was 14 millimeter of mercury, and pulmonary vascular resistance was 23.8 U/min. And exclusion of shunt anomaly, lung disease, chronic pulmonary thromboembolism, connective tissue disease, and HIV were also done. Vasoreactivity test with IV adenosine showed negative vasoreactivity test. And this was the evidence-based management algorithm of pulmonary arterial hypertension according to the ESC guideline of 2022. So our take-home message was, one of the gray zones of cardiology, this is complex etiopathogenesis, multidisciplinary approach of treatment, may require multi-drug treatment, and may require long-term treatment also. Thank you for your patience hearing.
Thank you, Dr. Mahmood, for your beautiful presentation. And now I like to request Dr. Professor Muhammad Saiful Islam sir to give his valuable opinion regarding this speech.
Thank you very much for your nice presentation. I think this is a diagnosis of exclusion, that is primary pulmonary hypertension.
Right, sir.
But for repeated syncope, we have not mentioned any other test. That a patient with repeated syncope for last 4 years, we should think other causes also, like carotid, brain, or other things
Right,
that,
sir.
may possible causes.
I have only mentioned about 24-hour halters, but we have done all the things because of time shortage and time constraints. I haven't shown all the investigations here.
Thank you. It should be mentioned only one sentence also.
Right.
Thank you very much for your nice presentation.
I have a
Question
question
to
to,
the
Dr.
speaker.
Mahmood.
One question to the speaker. Was there any murmur clinically?
Clinically, there was a soft systolic murmur of...
In which area?
Sir,
Second and third.
Right, sir.
Why there is systolic murmur and not early diastolic murmur? What was the reason of the systolic murmur in the second and third intercostal space? Is it compatible with the patient clinical diagnosis? We may get, as the pulmonary artery is hugely dilated, there is severe pulmonary hypertension, we expect early diastolic murmur.
Right.
That is Graham still murmur. Right. But why there is systolic murmur? Can you explain it? Tricuspid agitation murmur will be pansystolic murmur in the lower area, not in the second and third intercostal space. It is not compatible with the diagnosis of the patient.
Right.
I have one confusion. You have said MEPCA. CT reveals MEPCA. Okay.
Right.
So why not that the MEPCA is the culprit for this pulmonary hypertension? Because whenever there is irreversible change in the pulmonary vasculatures and shunt across the pulmonary and systemic less than 1.5:1, then we will not get any step up of oxygen in any level. Moreover, you have excluded the intracardiac shunt. So obviously there will be no oxygen step up inside the cardiac chambers. One may be the culprit lesion is this MEPCA, and we should be aware of it. I have seen many cases idiopathic pulmonary hypertension. I have done query, but I advise for CT angiogram to exclude the extracardiac shunt anomaly. Thank you.
So thank you, sir. Thank you for your tips.
Thank you, Dr. Mahmood, for your beautiful presentation.